signing in. Please remember that you can get CME. The instructions are on the emails that are being sent monthly. We also will have some time at the end of the presentation for questions and answers as well. So thank you, Gilbert, for coming, and you're going to talk a little bit about the supratentorial brain development.
Yes, thank you. Hopefully we'll have some questions at the end. I'm not sure they'll be answered. So Dorothy asked me to talk about supratentorial brain development earlier last year. I think Andre talked about the posterior fossa, so it's going to be the above the tentorium talk. So the objective is we want to understand what fetal MRI can reveal about cerebral development, become familiar with the appearance of the normally developing cerebrum, and review the role of MRI in evaluation of ventriculomegaly and associated abnormalities, since that's the most common referral for supratentorial anomalies in fetuses. So there are certain things that fetal MR cannot document because it's already happened by the time we can properly image a fetus, and that is the formation of the cerebral hemispheres and the cleavage between the two hemispheres. The formation of corpus callosum also is complete by the time we can image, and a lot of the neuronal proliferation has already happened. But what fetal MR can document is certainly the growth of the cerebrum, the cerebellum, of course, but we're not going to talk about that today, and the corpus callosum. Pretty much all of the neuronal migration we'll see occur, and along with that, the gyrification of the cerebrum, and then we will see the germinal matrix evolve and then involute. Other things that we can see if we work a little harder at it that we're not going to talk about today are findings of early myelination in the brain. We can also, with DTI, look at the structural maturation of the brain, and with MR spectroscopy, look at the metabolic maturation. However, these are still fairly experimental or research applications, if you want. So we're not going to talk about it. We're going to stay on the clinical side of the imaging spectrum. So we're going to talk, to follow this lecture, we'll talk about the growth of the cerebrum. We're going to talk then about gyrification, talk about the germinal matrix and cerebral layering that we can observe, and finally discuss a little bit about the white matter of the fetus. And then we're going to, in the latter part of the lecture, we're going to talk about ventriculomegaly. So the first thing that we can document, and until gyrification starts, is pretty much the only thing we can document except for a global assessment of the shape of the cerebrum, is the growth of the cerebrum. So until about 23, 24 weeks, we're mostly limited to kind of overall observations, but certainly we can measure the cerebrum just like the ultrasonographers can measure it, and the measurements tend to be fairly congruous. We seem to come up with fairly similar numbers. And for the cerebrum, then we'll measure the front to back diameter, you can see on the left, and the biparietal or bifrontal diameter, as you can see on the right, and this is pretty straightforward. And obviously, if you just look at linear measurements, the cerebrum undergoes tremendous growth in the time frame we can image it, which is about 18 to 20 weeks, up to 30 weeks, and much after that. So there's a tremendous amount of linear growth that can be documented and can be plotted. Catherine Limperopoulos' lab here has also done beautiful work looking at volume, and this is obviously much more reliable than single one or two measurements. And you can see, looking at the volume, that the increase is quite linear throughout pregnancy and quite remarkable if you extrapolate down to 24 weeks. So clearly, we can assess the growth of the cerebrum. What's more interesting is to look at the evolution of the sulci and the gyri, what we call the gyrification. You see some pictures at the bottom of your screen from these are obviously pathology specimens. The 17 and 20 week specimens on the left have no gyri or sulci. Only the Sylvian fissure is identifiable and is rather shallow. And then you can see already by 31 weeks, there are quite a few sulci that have appeared over the cerebral convexity, and you can see that the Sylvian fissure has started to kind of close upon itself. And finally, by 40 weeks, all of the primary sulci are there, which are the sulci you identify on the surface of the brain. And if you were to kind of look into the primary sulci, you would see that there are also secondary and tertiary sulci that have evolved. So there's a tremendous amount of generification that occurs in the brain in the late second and third trimester. The mechanism by which this happens is not fully elucidated. So on MR, at 23 weeks, there's basically no sulci to be identified. But already by 25 weeks, you can see that the central sulcus, it can be identified in a significant number of fetuses, not all, but a good portion of them. This is one of the earliest sulci we'll see, the earliest being the calcarine sulcus. I'll show that to you in a little bit. And then here's a older, this is actually a neonate, but it could be a fetus also at 28 weeks. And you can see already there are quite a few more sulci that have appeared. And you'll note, and this is pretty consistent, that the sulci, or the gyri, if you want, on the right, tend to be a little bit ahead of the gyri on the left. So when you look at a fetal brain, you can actually tell which is the right hemisphere, which is the left hemisphere. And whenever I look at fetal MRs, I always make sure that the right side of the brain is on the opposite side of the stomach. Because if they're on the same side, then usually that means there's something wrong. Though Dorothy and her team are always very good at letting me know when there's some kind of a situs inversus or ambiguous. So anyway, so by 28 weeks, you get more gyri that we can identify. 30 weeks, you can see that they're deepening. And already by 33 weeks, almost all of the primary sulci are present. And what will happen after that is that the sulci are going to become deeper, in the depth is going to become deeper, and then they will branch out into secondary and tertiary sulci. If you go in books, and this is from an article, a book derived from publications by Germinal, who was among the first one to kind of nicely map out what the sulcation age or the generification age corresponds to the fetus. So and I put a red arrow on the sulci that I find particularly helpful in kind of identifying to kind of quickly figure out the maturation of a fetus. So the calcarine fissure is usually the first one we'll see, and pretty reliably by 24, 25 weeks, and then the central sulcus at 26 weeks, and you can read this along with me. At 27 weeks, the posterior aspect of the superior temporal sulcus is there, and then by 29 weeks, the frontal sulci show up, and then a little later on, then the anterior temporal sulcus and inferior temporal sulcus. So any even a high school student can look at a brain and kind of tell you the gestational age, or at least the sulcation age of that brain. So this is not too hard once you kind of get an eye for it. And a lot of these landmarks are best seen on coronal images. So I do find the coronal and then the sagittal images the most important images to look at the maturity of the generification. So here is a calcarine sulcus, and it's only present on the right side because, again, the right evolves a little bit before the left, and this was about a 24-week fetus. By 27 weeks, you can see the central sulcus here in the sagittal image, very useful image. And in the back of the temporal lobe, you start to see a little depression here. This is going to be the posterior aspect of the superior temporal sulcus. So this is an excellent landmark, very consistent by 27 weeks. At 29 weeks, the superior and inferior frontal sulci show up. And again, you can see they're present on the right, but not quite there on the left yet because of that right-left asymmetry. And on the sagittal image now, we can see not only the central, but the precentral and postcentral sulci. And finally, by 32 or 33 weeks, then if you look in the anterior-most temporal lobe, then you should be able to identify the superior temporal sulcus on the right side here, and also the inferior temporal sulcus here. So those are present. So that by about 34 weeks, all of the primary sulci are present. And after 34 weeks, it's very hard for us to tell the difference between 34, 36, 38, 40 weeks, because the secondary sulci are much harder to assess. So the most useful gestational age range where we can give information about the adequateness of sulcation is from about 23 or 24 weeks up to about 34 weeks. So here's a 35-weeker, and again, pretty much all of the primary sulci are present. Now, the Sylvian fissure is a little harder to assess because it does tend to have some variance from individual to individual. But until about 23, 24 weeks, it tends to be fairly featureless. It may kind of develop a bit of a posterior corner here by 23, 24 weeks. At 27 weeks, then it should start to close. So now there should be an acute angle between this cortex here, which is the island of Ryle, and then the back part here. And then the disclosure will will come along progressively. And one can make measurements of the Sylvian fissure, but there does tend to be quite a bit of individual variation. So I do find that a kind of a harder landmark to evaluate as far as whether it's appropriate or not. But again, we're saved by sulcation, so usually that kind of helps us. So having said that, here is a child. This is a clinical case. This is not a normal case. Who had an MRI at 21 weeks because of a posterior fossa abnormality, and also had some facial and orbital abnormalities. And as I told you earlier, at 21, 22 weeks, there are no sulci to be identified, and therefore we are not in a position to say whether there are any abnormalities of gyrification that are present, because we cannot assess it. The ventricles here were a little kind of upper limits of normal, and one might say that the Sylvian fissures are probably a little more dull or flatter than one might expect, but this would be, again, a very hard call. I mean, this, I think, was called prospectively a normal study, and it looked pretty normal. But look at the same patient 12 weeks later, and now that gyrification has occurred, we see that this is a totally abnormal pattern. So this child did develop extensive abnormalities of cortical development, which could not be assessed at 21, 22 weeks gestation because this gyrification has not started yet. So this is one of the limitations we have when we do these early third trimester images, is that the sulcation has not occurred yet. So this is extensive. There are too many gyri here compared to what I've shown you. And this is what we find in polymicrogyria or cortical dysplasia, and pretty much everywhere along the surfaces of the brain, there are too many gyri. And I'll show you the postnatal of this same patient. And this patient also had a callosal dysgenesis, which is why the ventricles are a little peculiar in shape. But again, you can see this extensive polymicrogyria almost looks like cobblestoning in some areas, and just very extensive cortical dysplasias, to which, again, we were blind at the 21-week imaging. So this is clearly a limitation of just the nature of the process when we look before the sulcation starts. Is that good? Okay. Corpus callosum. So by the time we image the earliest fetuses, which is 18 or 19 weeks, the corpus callosum is already formed. What has not occurred yet is it has not achieved its full mature length, and therefore its relationship to the brainstem has not occurred yet. So an important landmark that is pretty consistent is that by 22 weeks, the splenium, the back part of the corpus callosum, should be on top of the callosal plate. So before 22 weeks, it will be in front of it. By 22 weeks, it will be at the tectal plate. And then after that, it should be beyond the tectal plate. To measure the corpus callosum oftentimes is hard because you need a perfect or near perfect sagittal image. Which is hard to achieve. And so most of the time we'll see where we get an image of a piece of corpus callosum and a different image where we see the other part of corpus callosum. But the measurements are not always easy to tell. However, even without measurement, if one can properly assess the position of the splenium, one can tell whether the corpus callosum appears to have normally formed by the relationship between the splenium and the plectal plate. Okay, so let's talk a little bit about the germinal matrix. The germinal matrix, until about 16 or 17 weeks, is composed of a single region called the ventricular zone, initial VC. We'll talk about that. And then the earliest images, again, that we can produce of the germinal matrix, these are diffusion images. Because it's very cellular, it tends to be very bright. And I do like diffusion images to look at the germinal matrix and the robustness of it. You can also see it on the T2 with images pretty well. But on diffusion images, it tends to be very bright, and it encircles the entire ventricles. You see it here near the median eminence. You see it here around the temple horns. And on an ADC image, again, this is reduced diffusivity as a reflection of the marked cellularity that characterizes the ventricular zone or the germinal matrix at this age. Around 18 weeks, then there's a subventricular zone that develops that will contain more and more of the neuronal generating cells, if you want, the germinal matrix, and eventually replaces the ventricular zone. However, by imaging, we cannot separate the subventricular zone from the ventricular zone until about 21 or 22 weeks. So until about 21, 22 weeks, so here's a 20-week fetus, we can really see only 3 structures. So there are 3 layers to be identified. So hugging the ventricles is the combination of the ventricular zone and the subventricular zone, because they cannot be separated. Then this very thick and bright area here is the subplate. And then that thin dark line is the surface of the brain, what we call the cortical plate.
Can you just go back to the ventricular zone? I mean, yeah. I can sort of see 2 layers there.
You can sort of see 2 layers. Well, that, my friend, is you have a good eye or a good imagination?
I have neither. Isn't there a darker internal and a grayer external?
Let me show you what it's like when you can see it for sure.
We talked about this being the Oreo sign.
Oreos? I never heard of that. So
Oreo cookies. You don't need.
Well, I heard of Oreo cookies. So now here's when you can see the 5-layer, which is why I think earlier I think it's hard to see. But when you can see the subventricular zone, you should be able to see a dark, then a bright, then a dark, then a bright, then a dark. And that would be the ice cream sandwich sign, the double deck ice cream sandwich sign. So whereas before 21 weeks, it's very hard to see. You might be able to see in some instances, but usually not. So between 21 and about 27 weeks, we should be able to identify this 5-layer. The first one, the one closest to the ventricle, being the ventricular zone. Then the next one, which is that bright line, is the periventricular zone. And then the third line, which is the grayer one, is the subventricular zone, which also includes the intermediate zone. The intermediate zone will become thicker and thicker as the neurons migrate out of there, and will eventually form the white matter. So this is the early aspect of white matter. Then the 4th layer, which is now bright again, is a subplate, which was very thick in the earlier fetus, and now starts to thin out as neurons kind of migrate through the mantle towards the cortex. And then the 5th line is the cortical plate. Okay? So those are your 1, 2, 3, 4, 5 layers. And Again, 19 weeks, 3 layers, except for Audrey, who sees 5. We wonder what he had for breakfast. Then by 20 or 21 weeks, now you can kind of see here maybe 1, 2, the periventricular zone, and then intermediate zone, then the subplate, and then the cortical plate. And then by 26 or 27 weeks, it all kind of vanishes. And now we're left again with kind of 3 or 4, and I'll show you why in a minute, areas. So now we get the cortical plate, and then the intermediate zone is pretty thick here, and then you get the ependymal layer. After 30 weeks, there's basically no germinal matrix left to be seen. So that thick rind of neurons that was seen along the layer, the margins of our ventricle is gone, and it's basically only ependyma that's left, except for a couple of areas. We know that by the thalamocaudate groove, the germinal matrix will stay around till about 33, 34 weeks, though on a fetal MR you can't really see it because you can't differentiate it from the basal ganglia that's next to it. So we know it's there, you can't see it. But there's another area where we can still see a little bit of germinal matrix, and that's in the deep frontal white matter. So here's a 30-week fetus on the left. This is a 32-week newborn. But you can see these little islands of gray matter signal in the deep frontal lobes in front of the frontal horns. And these are still neuronal elements that have not fully migrated yet. And these actually persist even now up to birth and a few weeks after birth. So we see those in every neonates.
Are they still proliferating, or is it?
They may be. I would assume so, because I mean they're there for a good 10 weeks. So I'm sure it's not just neurons that are waiting to migrate. I would assume that there's still proliferation and migration going on together. Here's a 35-week neonate. You see those. And those are important to know about because at times they can be mistaken for areas of white matter injury. Because white matter injury oftentimes tends to be dark on T2 images. So you want to know about that. And on a sagittal image, it's not just a little dub, it's actually a band. So these are all, again, neurons that are in the deep frontal areas. And we see them in every newborn, and by the time they're 3 or 4 weeks, then it's vanished. So, something to know about. I'm giving you all my tricks here, basically. Okay, besides germinal matrix, we also need to talk about the intermediate zone, which we said is an area where the subventricular is mixed in with the subventricular zone, but will eventually become thicker and thicker. So here in the 21-week fetus, you can see here's the plate, here's the subplate, here's the subventricular zone and the intermediate zone. And the intermediate zone, one thing that's peculiar about it is that it contains areas that tend to be very hyper-intense on T2 weighted images. And these areas have been called crossroads, or periventricular crossroads. And there are areas within the white matter that is characterized by a lot of hydrophilic extracellular matrix, and it's also areas where the axons tend to cross each other, which is why it's called the crossroads. And this is another important marker to know about because it can lead to quite a bit of confusion. Here's an older fetus. You can see it's fairly well, he or she, fairly well gyrated, but you see this kind of band of brighter T2 signal compared to the more peripheral white matter. And that is a normal finding in a fetus. It's also a normal finding in a newborn. Here, these are a little bright, so they don't project very well. But you can see that the subcortical white matter, even in this newborn here at 32 weeks, is not as bright as the deeper white matter. So the white matter by the ventricles tends to be significantly brighter. For a while, people in the literature would describe that as areas of diffuse excessive signal intensity, and they thought that this was a marker of white matter injury, and it turns out that it's basically all normal. Because all, especially if you have preemie newborns, it's all fairly striking. So that's good to know about. And this, again, disappears in the first few weeks after birth. So even in newborns, we see that. So that's good to know about. Okay, so we have about maybe 5 or 10 minutes to give some time for questions at the end. So the most common referral for fetal MRI for cerebral abnormalities, at least, is ventriculomegaly. Because with ultrasound, obviously, it's very easy to recognize the ventricles and the fetus and to measure them, and the ventricles measure too big, then more often than not, I guess, these fetuses are referred for an MRI. Is that fair to say? So ventriculomegaly is identified in 1 or 2% of pregnancies, and is defined as an atrium that's larger than 10 millimeters, or 10 and larger. I think it depends on who you follow, but most people say at 10 it's too large and more. And which means that 98 or 99% of fetuses have atrial measurements that are under 10. So that's it's a pure kind of statistical thing. There's a little bit of discordance, I guess, in how people classify ventriculomegaly. Quite a few authors will say that between 10 and 12 millimeters is mild, 12 and 15 is moderate, and more than 15 is severe. I got this from the textbook of fetal neuroimaging that Dr. Bulis co-authored. So if you disagree with that, then you can ask her about it. So that's in the textbook. Other authors will say 10 to 15 is mild and more than 15 is severe. They kind of skip the moderate. Sometimes Eva tells me that up to 11 is normal in boys. I'm still waiting to see the reference on that. And basically, the mild have a low incidence of anomalies. The moderate have a higher incidence of anomalies, and then severe, even higher, and severe tends to have oftentimes a poor outcome. Now, you want to measure the ventricles the right way. There's a right way. There's a wrong way. On an axial image in a fetal MR, you want to measure on an image that's through the level of the thalami and at the level of basically the tectal plate. So you'll be just, if you project just behind where the tectal plate would be, and you try to catch the corpus right there. So this atrium here measured 13.92 millimeters. Very, very accurate in our measurements, and I'm being sarcastic. If you do it in a coronal image, which is in many ways even more reliable, if you measure it right at the level of the tectal plate, so here's the tectum of the midbrain, so if you measure at this level, you should be right in the glomus, and if you measure right there, that's the perfect place to do it, and you get basically the same measurement. You don't want to measure it up here, because then if you have colpocephaly, if you have kind of strange paraventricular enlargement, you won't get reliable measurements. So you want to be closer to the tectum. Etiology, I think everybody knows this. One of the more common reasons, obviously, is hydrocephalus, so there's too much CSF in the ventricles. It can also be that the brain is not formed normally, so structural anomalies, the most common of which is agenesis or corpus callosum. But any disorder of cerebral formation can be accompanied by abnormal size and or shape of the ventricles. So it can be neural migration, it can be holoprosencephaly, it can be chromosomal abnormality. One cannot expect normal size and shape ventricles if the brain doesn't form normally. It can also be destructive, so that's the third kind of large category. And we'll see that commonly with infection or vascular events. Also, we'll see it in fetuses that have in utero intraventricular hemorrhages, for example. When ventriculomegaly is identified by ultrasound, MRI improves or detects additional abnormalities in about half of the cases. Again, I got this from Dorothy's textbook, so if you disagree with that, you can ask her, or her co-author, Dr. Bethline. Okay. Agenesis of corpus callosum is one of the most common reasons for referral. that we get, or suspected agenesis. There's an interesting paper by this author Craven that's referenced at the bottom in Clinical Radiology of this year, where they looked at over, I think it was 1,000 cases, fetuses that had ultrasounds, and these were, I think, level 2 ultrasounds, if I remember correctly, so not the top level, but pretty good ultrasounds. And what they figured out is that head ultrasound is a 97 negative predictive value, which means that when ultrasound says there's a corpus callosum, there's almost always a corpus callosum. It's very, very rare, and I'm sure in better hands it's probably 100%. That if the ultrasonographer says there's a corpus callosum, it's there. Where ultrasound is not as predictive is in the positive predictive value. So in that study, and from what I've seen here, that's actually probably reasonably accurate. It's kind of a 50-50 thing if by ultrasound there's a suspicion of agenesis or corpus callosum. 50% time will be there, and 50% it won't be there, but there'll be something else wrong, assuming that it's from ventriculomegaly. Or oftentimes there'll be something else wrong. And again, in agenesis or corpus callosum, as in any case of fetal ventriculomegaly, when we do fetal MR, we do find additional abnormalities. So this is what agenesis looks like, and you can see that this patient had mild asymmetric ventriculomegaly. I think all of you can recognize that in the absence of the corpus callosum, the interhemispheric fissure will extend and communicate directly through a third ventricle on a coronal image or an axial image, because the genu should always be here. And if you have a good sagittal image, then you can demonstrate the absence of a structure, which is not always an easy concept to grasp, but clearly there's no corpus callosum there. So that's the easy one, and this is an agenesis or corpus callosum that had otherwise a normal cortical structure as far as gyrification for age, and even the layering, you can still see a little bit there. Different prognosis is, here is a fetus whose ventricles were not that big, but was referred for agenesis or corpus callosum. And here we can see with MR the kind of things that ultrasound has a hard time seeing, which are abnormalities of supratentorial development. So the hemisphere on the right is abnormally folded, right? It looks like it's being pulled this way, so it's kind of almost like tethered in the mid-convexity here. And on the left side, you can see that there are irregularities here that will turn out to be heterotopias. So these are the kind of associated abnormalities that we look for and that do change the prognosis and the counseling of patients with agenesis or corpus callosum. This child had ventriculomegaly. You can see the atria measured about 15 millimeters, and it was a rule-out agenesis or corpus callosum. Again, ultrasound will not be able to identify that, but there was a very small structure here that was a genu. So we can see there was a very small piece of corpus callosum, and except for that, the rest of the corpus callosum was absent, and it seemed to be the only abnormality. And because Andre loves postnatal correlation, here's the postnatal MRI, which shows again this tiny little genu, but essentially complete absence of the corpus callosum. And there's not enough time to talk about all the wonderful genetics and the manifestations of callosal dysgenesis, but there's more and more interest in kind of classifying the type of dysgenesis that can be identified.
But would this one have a worse prognosis than complete agenesis?
If you believe the so-called experts, yes. So the dysgenesis tend to do worse than the agenesis. Everything else being equal, of course. Here's a patient who has ventriculomegaly. He does have, or she does have a corpus callosum. You see a nice genu here. I'm not showing you the splenium, but there was one also. And these were not small ventricles. They measure up to 24 ventricle millimeter. And this is, of course, one of the limitations of fetal imaging when we see a patient the first time, whether ultrasound or MR, is that it's only a point in time. We don't know the trajectory of things. So looking at this image, you cannot predict, is this going to get better? Is it going to stay the same, or is it going to get worse, right? So this is another limitation that we have when we counsel parents. We don't know. What the neurologists like to do best, which is to say, why don't you come back in a month and we'll see how you're doing. This is the corpus callosum of that child, so you can see those they identified. This is this child after birth, and this child actually did pretty well in the sense that the ventricles got progressively smaller as the cerebrum grew, and it seemed to be a pretty normal cerebrum. So this was a somewhat happy ending, I suppose. Now here's a child who was sent for rule out agenesis or corpus callosum and had microcephaly. And this is time for audience participation. Is this agenesis or corpus callosum? No. What's the diagnosis? Right, so this patient had bilateral schizencephaly, which, again, on ultrasound may not be necessarily easy to recognize because it's not always easy to see the cortical mantle by ultrasound. Here's another patient who was referred to us for ventriculomegaly, rule out agenesis or corpus callosum. And the diagnosis here is holoprosencephaly, right? So there's abnormal fusion of the hemispheres, and what kind of looks like colpocephaly. And the septum pellucidum, I guess, cannot be seen, but this is holoprosencephaly. So that's, of course, the advantage of MR is that we do see much better. Here's a patient who had ventriculomegaly. And this time, ventriculomegaly was associated with multiple abnormalities of neuronal migration. So you see these little dots here along the ventricles. These are heterotopias. You can also see that there's a focal thinning of the cortex here. Again, it's not fully gyrated yet, but we can suspect that there would be a significant abnormality of gyrification there. And here's the postnatal image. So you can see the heterotopias that are present bilaterally, and also this abnormally enfolded gyrus here, and you can see it here also. So that original fetal abnormalities turn out to be an area of regional polymorphism. So again, here's the fetal. It is really fascinating. So here's the fetal, and then here's the postnatal. And then one more case. We'll have a few minutes for our questions. I had to show at least one hydrocephalus. This is obviously severe hydrocephalus. I don't have the measurement here, but it's and sometimes it's not easy to tell if ventriculomegaly is due to obstruction or not. But when we see very large lateral and third ventricle like that, especially if we see a lesion in the aqueduct, then we can tell pretty certainly that this is obviously, and the head is big obviously, so this is obstructive hydrocephalus due to some kind of aqueductal stenosis or aqueductal web. So that kind of concludes what I had to say about imaging of the supratentorial space. We have about 5 minutes for questions.
Okay, do we have any questions from the audience who's called in? You can unmute and ask a question if you have one.
Do we have to unmute? I think we are on.
Are we?
Okay, sorry, we know someone's trying to ask, but we're not hearing you. Hold on a minute.
And try sign language.
Apparently we should hear them.
Yeah.
Someone's.
Let's see. Gilbert?
Can you try one more time?
Because it says up there, speaking.
We're user two.
Oh, we're user two.
Okay, so does anyone have any questions for Gilbert from this audience?
So I was really fascinated by that phenomenon of the neurons that are near the frontal pole that
Right.
are arrested. Why don't we see heterotopias more commonly in that area? If that is, I mean, you'd think that later on, as more and more risks of vascular compromise happen in the fetus that you would get an arrest of that process? That, for me, is not a common area of heterotopias.
No. First of all, I have no answer. I said that at the beginning of the lecture. But heterotopias, some of them clearly are genetic. But the ones that are not genetic, people, a lot of times they're due to ependymal disruption. So if you disrupt the ependymon, then you'll get some ependymal heterotopias. Whereas these are actually kind of, these neurons, they're already in the white matter. They're away from all that ependymal disruption stuff. And my assumption is that once they're there, then they're good to go. But I don't know. That's been confirmed pathologically. Yeah, I was showing you some, I show you pathological signs.
Very interesting. Yeah.
Any other questions? So definitely, I will have to say for the quote from my book, it's a little bit incorrect in that with mild ventriculomegaly, there's some larger series that suggest that a majority of the time you don't identify additional findings by MRI. And the majority of time, when it is moderate or severe, the majority of times you will find other anomalies. So when you kind of put it all together, you get that 50% rule. But I think because so many of the mild ventriculomegalies turn out to be normal, you really do have to have a large series to identify that 7 or 8% of abnormalities. So we do think it's useful and important, but I think a lot of our mild ventriculomegalies, we do end up not seeing anything additionally, which makes sense. But for all comers, the larger the beds, over 14 to 15 millimeters, the more likely we'll see something by MR. Well, thank you so much. It was fabulous. Wonderful as usual. And we'll be having a very interesting conference next month on ethics with counseling with Dr. Gilbert and Meg. So that will really be wonderful. So thanks again for coming today.
Thanks, Gilbert. So these slides will be available. I can just look at them. I guess they're